The way we treat stroke nowadays, acute strokes, is becoming, these are exciting times because we're now really trying to make a big difference in patients that some time ago had very little options and their prognosis was not as great. And I'm going to focus on summarizing 4 or 5 of the latest trials that have been published between January and March of this year that really have changed sort of the horizon in acute treatment of stroke. And these trials are this one's down here, Mr. Clean Escape Extend IA, Swift Prime, and Revascat, that really have built upon prior attempts to show that strokes that are the result of occlusions of big arteries, in sort of what we call proximal arteries, can be treated and should be treated with more aggressive ways than IV TPA. Now, these trials, these first 3 trials were very promising, showed us the path, and these following trials kind of followed on these smaller trials trying to come with the definitive answer to prove this concept, and unfortunately they failed, but they failed for different reasons, the design and the technologies that were used. And there was sort of a big disappointment a couple years ago about that, but finally these trials were able sort of to learn the lessons from this prior attempts and were extremely successful, as you will see. So basically up until 2014, the trials on intervention had showed that they were great at recanalizing, at opening the arteries, but somehow that was not translated into a benefit and clinical outcome. But they taught us that minimizing time continued to be of essence, and that was for lesson number 1. Now, bear in mind that about 1/3 of the acute anterior circulation strokes are the result of occlusion of a big artery, that is in the internal carotid artery or the first segment of the middle cerebral artery. And these are arteries that obviously are responsible for large territory of the brain tissue and tend to be large clots. And what we know is that if you do nothing, in general, these strokes have very poor prognosis with mortalities or severe disabilities in the 70 to 80% rate. So the prognosis is very poor, and the treatments that we had available, which was intravenous thrombolysis, for that particular kind of stroke, does not work as effective as sort of we want it to. In fact, the rate of recanalization is about 30% or so. And in fact, here's some data from some of the trials, IMS3 and one of the most recent ones, looking at the rate of recanalization at 24 hours, and it's about 35–37%, right? So we know that patients with such kind of strokes do better if we are to open the artery than not. And so based on that concept, all these trials were building up on that concept, but to try to take it to a larger audience and make it standard of care was more challenging than it proved to be at the beginning. So the reason why all the prior trials sort of failed was the times at which we were intervening were relatively long. It was a little bit of a mixed bag when you kind of look to this trial in a more critical way, and they were not using necessarily very strict criteria to select a very homogeneous group in regards to confirming that there was proximal occlusions in those patients that were actually going to be randomized to the arm of the intervention, or that the patients that were being treated intervention in the trial as a whole had a relatively small ischemic core. For all these reasons, and perhaps most importantly, because some of those trials were not using necessarily the latest technology that came available after or almost at the time that these trials were finishing, is all these reasons that we think now in retrospect that those trials failed and the new trials became successful. So I'm going to go very fast through this. I'm sure that Dr. Case will touch on this again, but just to give you a flavor of what we're talking about, the first big study was Mr. Clean, and really has changed the way we think of stroke now and sort of the pathways that we have to deal with now. This was a study was done in the Netherlands in 16 centers. About 500 patients were randomized. And they were randomized either to receive intraarterial therapy plus the standard of care. Standard of care could have been TPA or no TPA, depending on the patient required or not, or fulfilled criteria or not, versus just standard of care alone. Now, bear in mind that about 90% of the whole group actually ended up receiving thrombolysis, all right? So they had to be treated within 6 hours. This is also sort of a new concept in that it didn't matter what the NIH was as long as it was sort of disability. If they had a disabling stroke, if the NIH was 2 or 3 or 4, didn't matter, they were in this trial. They had to have a small core of ischemia, and it was sort of indirectly or directly measured by an aspect score that gives an idea of the size of the stroke, that the stroke is not too large by the time you intervene, because in a way, obviously, the prognosis is not going to be good anyway at that point, and you're not going to be making much of a difference. What happens here then is because of the selection, most of the patients that came into the trial ended up having terminal internal carotid artery occlusion, or the first segment of the medial cerebral artery occlusion, as you can see here. Even though they allowed interventional radiologists to use any of the approved devices, by then, the new wave of retrievable stents was catching on, and most of them ended up using actually retrievable stents rather than any other of the other technologies that were not as effective. So bear that in mind, that most of the patients receive this kind of treatment. So at the end, what that translates is that not only they had a better recanalization rate, but the clinical outcomes were much better. Now, for the first time, these trials are now showing that not only they can recanalize, open the arteries very well and fast at a high rate, but that it translates into clinical benefit to the patient. So we measure that with something called the Modified Rankin Scale, which is a scale that measures sort of disability, and the odds ratios and the statistics were favoring the patients that received the intraarterial treatment. So that means 0 to 2 means basically independence. That 0 is no deficits whatsoever, 1 is mild deficits, and you can go back to regular activities that you were used to before. 2 is that you have some disabilities, but yet you remain independent. So 0 to 2 kind of lumps all the patients that are independent or have no disability. So this is kind of the number we were interested in, and here we go. 33% of the patients in the intervention reached that, and statistically significant, significantly different. The ones that did not receive intervention did not as well. And this is sort of a graphic version of what I just said. So there's a big difference. There's a shift. When you move towards the 0 to 2, it's less disability, 4 or 5 severe disability, and 6 death. So there were many more patients that ended up on this end, and as a result of that, this trial made a big difference in how we now perceive that these interventions are beneficial. Now, the other big question was, they're getting all this benefit, but how safe is this intervention? And there was no difference in mortality, and the symptomatic rates remained very low, and no different between both arms. Now, shortly after then, other studies that were also being conducted around the world had to sort of be stopped and reviewed by the Data Safety Committee based on those results of Mr. Clean. And so some of these studies were stopped short of their intended goal, but yet they showed impressive results and very consistent to what Mr. Clean showed. And so very rapidly, one of them is Extend IA. They planned to enroll 100, but they only reached 70 because it was stopped based on those results that I mentioned. And in this case, they were including patients that had received that had anterior circulation occlusion, very similar to the prior study. And in this case, they exclusively used this stent retriever, the solitaire. So all of them were receiving this stent in particular. And they went sort of a step further in trying to make sure that they were including patients with a small core. So they used a sophisticated imaging to include patients that had a small volume of 70 mLs. Again, they were including patients up to 6 hours. Whether or not they had received TPA was not an absolute requisite. So in the primary outcomes was reperfusion. The reperfusion rates were definitely very high. And there drops in the NIH, in the improvement in the clinical exam at 24 hours was dramatically and statistically different, and those that had the intervention versus those that didn't. So very similarly, if you look at the modified ranking scale, there was a huge improvement and gain from those that had the endovascular therapy of 71%, ended up in this group of 0 to 2 versus only 40% with a statistical significance. Again, just to show you that most of the cases ended up being M1 occlusions or ICA occlusions. And that the mortality rate, if anything, favored the group in the intervention. It was about 50% less, definitely not worse. And the symptomatic rate was also very low. Another study was the ESCAPE, 316 patients, 22 centers. Again, stopped early due to a previous study of Mr. Clean, and at that time it was shown to have some efficacy. And so here are the results. This particular study included patients up to 12 hours, all right, bear that in mind. Again, also included patients with a small core based on an aspects score, which is a scale that I think Dr. Case will review later, and reflects the size of the stroke at the time of the decision making to intervene. And again, 75% of them had received IV thrombolysis by the time they ended up in the intervention arm. Once again, what it shows is that there was a benefit towards intervention, 0 to 2, showing a significant improvement versus those that just receive IV TPA or standard of care. There was, again, mortality was lower, if anything, favoring the patients that received the intervention. And the symptomatic rate was no different. This is just to give you a flavor that, and this was consistent in all the other, for all studies, when they looked at the subgroups, there was really no significant heterogeneity, and it was, the results were favorable no matter whether you were above or below 80, no matter if your NIH on a baseline was more severe or not, etc. So all the subgroup analysis showed equal magnitude benefit. Even though this study went up to 12 hours, only 49 patients were in that sort of range of 6 to 12. So right now we cannot say much about that time frame. So 0 to 6 continues to be sort of the time that we feel that this studies show benefit. Then came another study called Prime Swift, randomizing 196 patients, again, including patients with proximal arterial occlusions, including the ICA or the M1s. Again, this one comparing exclusively the solitaire stent retriever versus IV TPA alone. Again, focusing on patients that had a relatively small core and that had significant disabling deficits, and included patients up to 6 hours. And similar sorts of benefits, as you can see here, very similar to the prior slides that I've shown you. Mortality was no different, and symptomatic rate, again, very safe. Actually none in the intra-arterial And once again, just to give you a flavor of the subgroup analysis, there was similar benefits on all the different subgroups. I want to point out here, and they had received patients from outside the main hospitals that were participating. So this will be patients who were transferred to centers that were participating in the study, similar to what we will be having here. We have already received a fair amount of patients from nearby hospitals, and that even though the numbers are lower and therefore from the statistical standpoint it doesn't reach a significance, the trends and the magnitude were also sort of in the right direction and very favorable. So it doesn't matter if you do the process right, patients that come from outside the hospital should also be benefiting. And then the latest study was Revascat, was done in Spain, and similarly patients with proximal anterior occlusions. This study included patients up to 8 hours with significant disabilities and a small core, and once again they show that the outcomes were very favorable towards intervention, with 43% in the 0 to 2 rate versus 28%. Notice that the improvement of the NIH or the neurologic deficits dramatically favor also the patients that receive thrombectomy, and this is measured at 24 hours. And here's a similar sort of pattern with recanalization rates for all these trials that are 65 or higher, 65 to 80%. Mortality was no different, and the hemorrhage was no different. So here's a comparative summary table of all the different trials, and perhaps it's easier to kind of appreciate it this way. So the NIHs, even though they just said significant patients, that they were including patients with significant neurologic deficits, it translated into NIHs that were kind of hovering around the 16, 17. This was relatively severe strokes, no surprises because these are big occlusions of proximal arteries. There were small cores, however they measured it. It ended up that the aspect score reflected that, aspect scores of 7 to 10 basically. The time windows was 0 to 6, and even though this one is up to 12 and this one is up to 8, the number of patients beyond 6 hours in these two trials were very small, so we cannot say much about that at this point. And the use of TPA was either 100% or significant, at least 2/3 or more. The onset to randomization was very fast, and bear that in mind. This is intervention we're talking now. This is just not IV TPA. So now it becomes more complex. The whole process becomes more complex. So the onset to TPA was relatively fast. This is the time from onset of symptoms to receiving the drug. This is not door. This is onset. Was very fast, hour and a half to 2 hours max. The time from the CT to groin is now from 60 minutes to an hour and a half, roughly. The onset to growing time ended up being around 3.5 hours to 4 hours. So again, you get the flavor that these are patients that are sort of put through the process very fast, so that at the end, the time from the onset of symptoms to reperfusion ends up being under 5.5 hours, with the exception of this trial. There are reasons for why it extended a little bit more. But most of them are going to be under 5.5 and closer to 4 hours. So this is very fast. And this is the kind of things that we're doing already in our institution, like with the example of the patient that I showed you earlier. The rates of recanalization are high, are 60–80%, but as opposed to others, this time it is translated in a clinical benefit to patients that ranges from 30 to 70% patients ending in the 0 to 2 range of the scale of the MRS, which is reflects independence. Now what that means is that the numbers needed to treat the patients that you need to treat to obtain one good result is very small and ranges from 3 to 7. So that is impressive. The symptomatic rates remain very low. So because of that, we have sort of adapted our algorithm here in our institutions in a way to reflect the results of those studies. So basically, acute ischemic strokes with disabling neurologic deficits, with or without TPA, aren't going to be considered for intervention as long as they are within 6 hours and as long as we see evidence of M1 and ICA or basilar occlusions. With a relatively small core reflected by this scale, and as long as there's also a small core reflected by this criteria of making sure that whatever we see of the ischemia is contained within the small area of the arterial territories. We have shared this protocol with neighboring hospitals so that they follow exactly the same algorithm that we do here, so that when they call us with a patient in a Manatee hospital, we're not going through this and questioning, because we know that they have followed this and we just accept the patient. So in conclusion, safe and highly effective procedure. This intervention, these algorithms are safe and highly effective procedure that really save lives. As you can see, the mortality, if anything, is favoring intervention. And reduces disability. And this happens when patients are selected carefully through clinical assessment, through evidence that there's a small core. When we use the right technology, and in this case, we're talking about the retrievable stents that make a huge difference in the success of retrieving and pulling out the clot effectively and safely, and doing this fast. And we are now, just like on our door-to-needle goals is 60 minutes, our CT to groin goals are 60 minutes, and CT to reperfusion is going to be 90 minutes, and I'll have data on that next year, I hope. And in summary, all these studies, what they show is an absolute benefit of intra-arterial therapy on this MRS of 0 to 2 and 90 days. They range anywhere from 13 to 31. This translates in a benefit of a number needed to treat for benefiting one patient that ranges between 3 and 7. Not many therapies can say that. Now, despite of our success, keep in mind that despite of the ranges that I showed, 30 to 60% of patients doing that well and falling in this category of independence, the remaining 30 to 60% don't do well. So there's still a lot of work to do, a lot of research to do to try to understand how we can kind of eat into these numbers and improve them. There was no significant increase in the rate of symptomatic hemorrhage, as I showed. And here are some of the unclear issues still that remain, and hopefully we'll have answers to some of these questions later on. And some of them are, we need to delineate better if this kind of therapies are going to be useful in patients that are ineligible for TPA, patients that have strokes on awakening, patients that come to us beyond 6 hours, or that have occlusions, the M2, for instance. So these are all questions that are still out there and need to be solved. Now, so for now, what we need to avoid is using this therapy in patients that have large infrared cores, either measured directly with imaging and reflecting cores bigger than 70, or reflected by aspect scores less than 5, and acute strokes that are beyond 6 hours. Thank you.